Okay, it's 12:05. I think that we're going to go ahead and get started. Again, your mics are muted, but you will have the opportunity to ask questions at the end. So today we have the great pleasure of introducing Dr. Arlene Foston. She is the Associate Director of the Neuropathology Core here at the Alzheimer's Disease Research Center. She has both clinical as well as research interests in neurodegenerative diseases. Dr. Foston completed her med school at SUNY Downstate, a residency at the Mount Sinai School of Medicine. She did a fellowship at Cedars-Sinai in Los Angeles, and then finally her neuropathology fellowship here at NYU. In addition, many of you have probably seen Dr. Foston around the halls at the ADRC, as she is one of our busiest study clinicians on the team. So we're so lucky to have her here today to speak about brain donation, what we learn, and how it can help you and your family. So Dr. Foston, a very warm welcome to you.
Thank you, Ashley. Such a gracious introduction. Good afternoon, everyone. Thank you for joining us today. I hope you all are well while you're home, and I hope you're taking advantage of all the opportunities to learn from the comfort of your home. Okay, so let's just begin. I wanted to first show you the structural architecture of the brain. So this is a 3D printed brain that we got from the radiology group here at the ADRC. And it's the actual size of a normal human brain. And as you can see, there are two hemispheres of the brain. So everybody's brain sits here, and you have your right side, your left side, and you also have here at the base your cerebellum, which helps you with balance and such. But we'll get into it. Usually when we're all together, I can pass this around and you can get a feel for what the brain, different gyrations would feel like. But hopefully later in 2021, we'll get that opportunity. So let's go ahead with the talk. Okay. Let me just click here. Okay, so what is dementia? Dementia is a broad category of brain diseases that cause a long-term and often gradual decline in memory or other thinking skills, severe enough to affect a person's daily functioning. Now that's key. When it's affecting your daily functioning is where we say that you're in an early dementive phase. As you get older, there may be things that take you maybe a little longer. Maybe you forget that celebrity's name, but it's not enough to say that you have a cognitive deficit or a memory or thinking problem. So dementia is considered a syndrome because it is a group of thinking and social symptoms that interfere with your daily functioning. Again, I bring up the term mostly dementia because, I think that's in your way. I bring up the term dementia particularly because not all dementia is Alzheimer's disease causing. Okay, people can have more than one type of dementia, and often that's the case, in which case we would call it a mixed dementia syndrome. Okay, so literally, here's dementia seen as an umbrella term, okay? And it's used to describe a range of symptoms, which I mentioned. So 50 to 75% of cases are, in fact, due to Alzheimer's disease. The second most common cause of dementia is vascular causing. So if you have hypertension, diabetes, don't get scared. It doesn't mean that you're suddenly having cognitive deficits all of a sudden, but those changes in your blood vessels over time will take a toll not only on your heart, but also on your brain. So that's why you have to be very mindful of this whole healthy living that's being promoted in the health community. And kind of in general, it's almost become part of popular culture to stay fit, stay red, and try to eat as many whole foods and stay away from processed foods. So we believe that also will help you with your vascular system throughout, from head to toe. The third most common cause of dementia is Lewy body disease. It accounts for 10% to 25% of cases. Now, Lewy body disease, what happens is you present with memory deficits initially, and then secondarily, you're going to develop some of these Parkinsonian symptoms. You know, when you hear people have Parkinson's disease. So Lewy body disease will look like that, except your memory goes first, and secondarily, you'll get that stiffness, the shuffling gait, that kind of frozen but in your body look if you've ever seen somebody with Parkinson's disease or the shaking. The fourth most common cause of dementia is frontotemporal disease, which accounts for 10 to 15% of dementia. With frontotemporal disease, the most common symptom that you'll see first is a change in behavior. Most often it presents in inappropriate behavior. People who were once reserved are now no longer reserved. They have no regard for people's feelings and just kind of, in a sense, not appropriate. You're almost afraid of what's going to come out of their mouth. Okay, so this lists the many, many types of causes of dementia that we know of. Over here on the top left, we have the neurodegenerative causes, which we just discussed. Also, some other ones is hippocampal sclerosis and many other neuropathological terms. Again, like I discussed, vascular disease could be also a cause of dementia. I discussed early vascular causes such as hypertension or diabetes, but all in all, the ones that are really going to start creating effects on your memory is when you develop a stroke or an infarct, or you develop what are called small infarcts or lacunar infarcts or TIAs. There are also familial causes of vascular disease. They're called amyloid angiopathies, which we'll talk about later on. And then, of course, any inflammatory causes, infectious causes, they can cause dementia. It won't be long lasting or prolonged if they're treated, right? But if people have infectious diseases that aren't treated at all, it'll present just like an Alzheimer's picture, except it could be prevented or it could be treated rather. Last group of causes of dementia are called prion disorders. So these are a very particular set of diseases, and they cause a very rapid form of dementia. So there are people who will present from their initial presentation to death will be within 2 years, okay? So going on to other causes of dementia, there could also be toxic and metabolic causes. Alcoholism, being vitamin B12 deficient will also take a toll on your neurons, your nervous system. Folate deficiency. Hypothyroidism, believe it or not, is also something that can affect your memory. Having liver disease, which could be secondary to the alcoholism, let's say, or any other kind of insult causing a chronic hepatitis. Any metabolic diseases, whether you're basically, if there's a imbalance of your electrolytes in your body. So a lot of times you'll have elderly people who are suddenly confused. They come to the hospital and a lot of times they just need fluids. So it's that dehydration and the buildup of those molecules in your body, and the imbalance can also affect your brain. Other conditions, tumors, naturally, and hydrocephalus. So hydrocephalus is when you have too much cerebrospinal fluid in your ventricles. And there are people who will suddenly have problems with their memory, trouble with their balance, and also kind of having urinary symptoms. So when you put all that together, and together with an image taken by MRI, which is why radiology is also a very important tool to help us in diagnosing causes of dementia, we would be able to readily see, hey, this person has way too much CSF is being produced, or not, CSF is for some reason not circulating out of the ventricles and going through its proper channels, and they would need what's called a stent to remove some of that CSF tissue, distribute it where it's supposed to be, and then you'll see that person good as new, as if they never had any deficits. So of the core mental functions, these are they're listed down here. They are memory, communication and language, ability to focus and pay attention, reasoning, judgment, and visual perception. So these are the aspects of mental functions that we look at to see if they're impaired, and we evaluate in order to determine if someone has any level of cognitive decline. So at least 2 of these domains must be significantly impaired to be considered, for that person to be considered to have dementia. So 2 lobes of the brain primarily involved in concentration, which I'll show you here. 2 lobes of the brain that are primarily involved in concentration are the executive center, which are in the front of the brain here in the frontal lobe, and also here at the anterior aspect of the parietal cortex, or known as the prefrontal cortex here. Okay, so just to review the different parts of the brain, here you have the frontal lobe, of which you have 2. This was asked before in a session, whether or not these lobes are bilateral or do we just have one. So you have your frontal lobe as described in the image, and you're going to have 2 of each. Same goes for your parietal lobe here, which is more of your language center. You have a left and a right. You have a temporal lobe here, which is the big discussion center of discussion when it comes to Alzheimer's disease. It houses your hippocampus and your memory center, so to speak. And your occipital lobe is over here in the back of the brain, and it is involved with visual perception, how you see things and interpret them. So all the lobes of the brain, though, none of them work in isolation of one another. There is a constant transfer of information from your brain stem into one lobe, back to the other, and so on. So the brain is really quite a complex organ, but we're just trying to kind of simplify it and give an overview of the main functions of the different areas. Now, just to further explain, for example, damage to the frontal lobe is what you would see more likely in frontotemporal disease, which is what I mentioned before, where someone now they were appropriate and now they're very inappropriate person. So your judgment would be thrown. Damage to the temporal lobe, as I mentioned, would be with memory. Your parietal lobe affects language. And for example, somebody who their native language was in English, and if that area is damaged, suddenly now that person starts speaking more in their native language as opposed to English. So things like that could happen. So let's delve into Alzheimer's disease, it being the most common cause of dementia among older adults. As I mentioned, it causes 50 to 75% of cases of dementia. It's the 6th leading cause of death in the United States, believe it or not. Those are stats still the same as of 2019. As of 2020 with COVID, I don't know if that'll change. COVID has really been climbing the ladder as a cause of death, unfortunately. And there are 5 main groups with different molecular genetic associations that have to do with Alzheimer's disease. So, sporadic, late onset. Sporadic late onset Alzheimer's disease is the most common type of Alzheimer's disease. When we say late onset, it's usually saying the onset of disease is from 70 years old and above. Familial late onset usually can happen as early as the 40s, but usually it's people maybe in their early to mid 60s that are maybe showing symptoms. That's what we call maybe some late onset. Actually, sorry, the familial late onset is more in your 60s, maybe late 60s. Familial early onset AD, those are people start feeling memory deficits in their 40s, their 50s, which is quite early to have deficits. And then you also have Alzheimer's disease associated with Down syndrome. Down syndrome is associated with the A beta protein, which I will talk about. And very many of Down syndrome patients have Alzheimer's disease and will eventually develop it, usually in their 40s. And the other type of Alzheimer's disease is associated with other degenerative diseases. Now, just to bring home kind of a fact. A lot of people talk about Alzheimer's disease, does it run in my family, the genes. A lot of work has been done to see the familial versus sporadic types. And I want you to know that familial types, where it runs in families, are the most uncommon type. Here at the center, we see that more commonly because we are an Alzheimer's center. And so we pool a lot of those people and a lot of those cases together. But throughout the US population, the most common cause is sporadic late onset Alzheimer's disease. Now, that isn't to say that it's not associated with molecules. So I'm sure you've been told about presenilin 1, presenilin 2, ApoE3, 4, those are the molecules that are associated with sporadic onset Alzheimer's disease. But that doesn't mean that it is passed on from family member to family member. okay? Just to let you know the difference. So why is brain autopsy so important? The examination of the brain after death is currently the only definitive way to diagnose a specific neurodegenerative order of an individual. Why is that? When you're alive, the brain is an organ that doesn't just regenerate. It doesn't just regenerate like your skin, you may get a cut on your skin and, new skin comes back. It's not like that with your brain. When an area is damaged where the neurons die, the neurons don't come back. It heals itself, but it doesn't regenerate. So it's one of those things, if the area is damaged, it's gone. So while you're living, we can't also just take out different parts of your brain because you're going to need those parts. So after death is when we're able to sample a sufficient amount of areas in the brain to adequately diagnose whether somebody has had dementia, number one, and secondarily, what was the cause of that dementia. Secondly, the autopsy enables study of the molecules involved in the disease process. As I just briefly mentioned, the ApoE genes, the presenilin genes, the A-beta 42, all these molecules that are involved in the disease process could help us to find new drug targets and new drug treatments. We also believe that the brain autopsy provides families with some closure. If you feel like, your family member, they were suddenly inappropriate or suddenly not knowing who you are or what was going on with them, it could be very frustrating. And sometimes, actually not sometimes, oftentimes you want to know, well, why did this person die? How did this affect them? And just kind of make sense of the clinical history that they had with the postmortem information that is received. We also have the autopsy as a tool to help family members assess their own risk for developing the disease and to seek help and maybe make plans for the future. This is for those who do have a gene that runs in their family, or they notice a lot of members of their family end up with the same clinical symptoms. So we try to see how the different tissue or the blood that's drawn and what we can learn from it, and then help the family members figure out what their next steps would be. So looking here, we have two brains. I wish I could ask, which do you think is normal? Well, I'll let you know. The one here on the left is our normal brain, okay? And this is our diseased brain, or our Alzheimer's or demented brain. The very striking difference that you can notice right away is that this brain on the right has many, many spaces, which we call sulci, okay? The spaces are wider than normal. Why are they wider than normal? Because the brain is shrinking. If the tissue is shrinking, then the spaces are going to enlarge. So this brain here on the right is a severely atrophic, which, will mean shrinking, brain. Okay, and here on the left, this is what your brain should look like. Your gyri should look voluminous. Your sulci, which are the spaces in between, should be tight, not too tight, but tight enough where they're all kind of lined up. The normal brain weight is usually anywhere between 1250 to 1450 grams. Okay, so here in the Alzheimer's brain, it could be anywhere from 1050, that's 1050 or less. I've had brains as small as 800 grams. Now that's a very big difference from a really healthy 1300 gram brain. Now, normally as you age, you do lose some brain mass, but it's not going to be to this extent. And it's not going to be as so pronounced like in the frontal or parietal area. It's a very gradual, very minimal loss of mass, maybe of about 200 grams, but not to this extent. This is just an arrow pointing out your gyri. And over here, the arrow pointing out the very widened sulci. Now looking at the brain at another angle, so not just front to back, but here on the side, right? So what we would call your lateral sides. So here, again, this is the front of the brain here. This is your frontal lobe, parietal, occipital, okay? Over here is your temporal lobe and cerebellum. Now again, which is normal, which is diseased? I'm sure by now you guys know. Over here on the right is our Alzheimer's or demented brain. Again, look how wide the sulci are due to the shrunken gyri. Shrinking gyri, widening the cell size. Same concept here, okay? And here, just so you know in the image, here's your cerebellum, and then here's your brainstem. Same here, cerebellum and brainstem. Now your cerebellum does a lot of the coordination, a lot of the balance. When you come here at the Alzheimer's Center, we like to see how you walk, we have you close your eyes, see if you can maintain your balance. All that is to also assess your cerebellum. Your brainstem, just so you know, houses all of your cranial nerves. So when we have you look left to right, we want to see how your eyes are moving. We want to see if you're able to follow our directions with like finger to nose test, things like that. So it really houses all of your main cranial nerves, a very, very important structure, okay? Here's some more images here. So again, let's see which is our normal and which is our disease. So here on this aspect in the top left, in picture A, this is the lateral side of a normal brain, okay? And here in B is that same, and the top right here in figure B is the same normal brain, except on the medial side, okay? So let's go back in A. This is the lateral side, so this would be this side of the brain on the outside, and the medial side is the inside part that you can't see. It's just flipped on the other end, okay? So here again, if you can notice in figure B, look how nice and tight the gyri are, okay? And then look how tight the cell side, the spaces are, which is very good. Here in the middle, I get asked a lot with a question of what this is. So here in the middle, where you kind of have this membrane covering, is your lateral ventricle. And that's a normal space that you're going to have in the brain, okay? Now coming down in figure C on the bottom left, you'll notice some widening of the gyri, widening of the cell side. Not as dramatic as the images that I showed you before, right? So let's go back. Look how wide this is. Very, very dramatic. A little less dramatic here, but still apparent. This is too wide to be normal. And then here's the medial aspect of this same brain in C. And again, not as dramatic, but you notice the spaces here of the cell side, okay? And then here you looking at the ventricle again here. Here the membrane is a little bit cut, but that's a natural space that's there, so that's okay. Now here, I show you this cartoon of the brain because it's a little bit, it's a little bit easier now to appreciate the brain from another angle. So the way, when we have these brains here, okay, this is the front of the brain here, I'm wearing the brain. They're really hard to assess in one way. So we look at it in a multitude of ways. So I had us look at the brain full and whole, and that's how we observe it too. As a neuropathologist, we look at it, we make our observations, we write it down in the report, whether they're shrunken. Then we cut the brain in half so that you can see the lateral aspect, which I talked about, and the medial aspect, which you can't see here, but you would be able to see if we cut in half. The other thing we do with the brain is that we cut it. We cut it from front to back because there are other architectural structures that you want to see. For example, the hippocampus, which is housed in the temporal lobe here. You can't see it unless you cut this brain in this direction, which we call kind of bread loafing, and we call it coronal sections. So getting back here to the slide, right? You can see it here that the brain is cut bread loafed. Here are our gyri, which I've been showing you throughout. Here in the middle is the lateral ventricle, where you'll have some cerebrospinal fluid flowing through. And here that you have here in the medial aspect of the temporal lobe is your hippocampus. This little guy is in charge of our memories, okay? So here it is right here in a healthy brain. And over here on the right, here you have it in an unhealthy brain, an Alzheimer's brain. Look how much smaller this hippocampus is. See this hippocampus? And look at the parahippocampal space. Look how wide that is. Now it's so wide because look how much this hippocampus has shrunken. Look how much the brain itself has shrunken. So when you see a picture like this of these severely enlarged ventricles, points in the direction of Alzheimer's disease, okay? Just kind of honing in the point. Now here is a real view of those sections, not those exact sections, but relatively the same. Here we have a star representing what would be the hippocampus, but it's shrunken so much it's barely even visible. And then here you have again the parahippocampal space, wide, not as wide as what we saw in the cartoon, but wide enough. And look at these ventricles. Look how big they are. Now, you're not supposed to have such rounded edges of the ventricles. They're supposed to be kind of more pointed to tell us that they're normal. Okay? And again, note all the shrinkage here. Now, here on the right, this is just a higher power view of the same, showing you how shrunken this hippocampus is. So now that we have looked at the brain in what we call a gross or macroscopic way, we have to look at the brain on a microscopic level. Now, this is what we actually do with the brain donations. This is what I actually do. We look at them, we define everything that I went through with you, whether it's atrophic, the hippocampus, what it looks like. We also look to see if there are any infarcts. I didn't show you guys any pictures of infarcts in those images, but we look for all that. Then what we do is we need to look at everything under the microscope. Here is a list of the 15 sections that are customarily examined for dementia cases. Throughout the literature, it is shown that these are the areas that are predominantly affected in all types of neurodegenerative diseases. Now, in these areas, though, we are going to look for specific things to tell us whether or not it's Alzheimer's disease. These specific things or pathologic changes that we look for are beta amyloid plaques and neurofibrillary tangles that are full of the protein tau. Now, I'm sure you've heard of these terms. And what they are they are abnormal deposits of proteins, and they basically burden your brain. They're found throughout the brain, and the problem is that the brain is not able to get rid of them. So it's not clearly defined whether the brain is not able to adequately get rid of them or they're overproduced. But all in all, these amyloid plaque and tangle burdens, they stop healthy neurons from functioning. And so these healthy neurons lose connections with other neurons, and the neurons die and they shrink. So here in the amyloid, we use this brown staining of amyloid itself to stain the plaques so that we can see them. The neurofibrillary tangles seen here, they're brown because we stain them with what's called tau. That's the stain that we use to identify that protein. Now, let me give you an idea of what a normal neuron should look like. So on the left, here are these neurons. They're triangular. You kind of have this circular nucleus. Oops, sorry. You have this circular nucleus, and in the middle you have this really dark purple dot in the middle, which is your nucleolus. So look how healthy and plump they look pretty good. Look to the right here. This neurofibrillary tangle now has, you see this like flame-shaped, kind of darker purple, neurofibrillary literal tangle in the neuron. And now look at this nucleus. You can't really identify it. It's smudged compared to here. Look how nicely you see this round nucleus, this little circular nucleolus in the middle. And over here, it's just smudged. It's degenerating. Other microscopic findings that are associated with Alzheimer's disease that we see under the microscope, one of which is congophilic amyloid angiopathy, or CAA. So CAA is composed of the A beta protein, the same protein that burdens the plaques that you'll see in the brains. So over here, what you basically see are vessels that are thicker than usual. Look how thick and pink this vessel is, okay? Really thick, really pink, and we use different methods to highlight them. We use Congo red, which is kind of an immunofluorescence, so that you can notice it, and we also use the A beta antibody immunostain, so that we can also identify them. Why is CAA important? Well, if we have a brain and we noticed a bleed and the person didn't have a stroke of any sort, but they had CAA, we can see CAA as a cause of that bleed. It is a cause of bleeding in the brain. Just because you have CAA doesn't mean you'll have bleeds. It's just one of those findings that's associated with AD. It's not causative, but it's associated. Another finding often in Alzheimer's disease brains is granulovacuolar degeneration, which is again just another term for a different type of degeneration of the neurons. So again, look at these neurons. Look how smudgy they look. The granulovacuolar degeneration is specifically these areas that look kind of like grainy in the cell body and contributing to the degeneration of that neuron. Last but not least, once we're able to look at the brain, we look at it grossly, we look at it microscopically, we issue the reports, and now we're able to say this person had Alzheimer's disease, it was severe, but they also had vascular disease, maybe they had CAA, maybe they had Lewy body disease. We were able to do that. So then now we're able to categorize that brain and that level of disease. So how do we apply that now to the community at large? We do it through research. Now, here I have just one of the research methods, analytical methods, I should say, that have come out of our laboratories here at the ADC, of which we have many. And it is the combination of our imaging, is the combination of our bench work of the lab, is the combination of the pathological diagnoses that allows the research in Alzheimer's to be possible. We're one of about, I think, 31 Alzheimer's centers in the country. I'm not 100% on the number, but I don't think it's much more than that. And we are extremely collaborative in a way so that hopefully everyone who has any idea of what's causing this disease can put that to work. And the beauty of the tissue, like the brain is so big and so vast that one brain is able to be shared amongst thousands of researchers, not just here in the US, but also worldwide. And that's important because we need the tissue in order to make these discoveries. And the discoveries are only made possible through you guys. So just to explain a little bit here of what you're seeing here, this is one research protocol that we performed using proteomics. I don't know if you've heard a lot about omics, like there's genomics. There are studies that are looking at the genes, at the DNA. So with proteomics, we look at the proteins. So remember the proteins that I had mentioned, right? A beta in the plaques, tau in the neurofibrillary tangles. So what we're trying to do is we're trying to zero in on those proteins and to see what it is about them that makes them different. What is it about them that are similar? And if we can target any of the peptides within those proteins to maybe come up with some other therapeutic possibility for the disease. So just to go over the process of brain donation, at the time of death, just so you know, all tissue begins to rapidly degrade. So in order to ensure the greatest research and diagnostic value for brain tissue, it's essential that it is removed as quickly after death as possible. Now, that doesn't mean an hour, 2 hours, you know. When you lose somebody, oops, sorry, we're done. When you lose somebody, it's really an emotional thing. It's very hard. And the fact that our participants are able to think about us and their families are able to think about us at this time is really so generous. So anywhere between 12 to 24 hours is more than enough time for the brain to be harvested. We work with the families. We do not interfere with any burial plans. We talk about the plans with the families, and we are able to accommodate them in any way we can. Okay, so all persons involved with the care of the donor, I can't stress this enough, should be aware of the planned autopsy. At the time of death, your mind is in all kind of places. So this could be one of the things that you hopefully don't have to think too much about. There will already be a plan in place, and all that could be talked about beforehand. Okay, well, that ends my presentation. Thank you so much for your attention, for your donation, or if not donating, for your interest in the study of Alzheimer's disease at all. Any questions?